In terms of a bit of background, so amyloidosis is a condition where a malignant plasma cell clone in the bone marrow is producing an amyloidogenic light chain which deposits in organs causing tissue damage. So you have to tackle both the malignancy in the bone marrow and also the organ damage, which can make it particularly challenging. The mainstay of treatment first line is bortezomib, which is established. And it's been shown that the malignant plasma cells in amyloidosis respond particularly well to proteasome inhibition. And as a result, that's why Ixazomib is an exciting drug as a new oral proteasome inhibitor, which can then be applied to amyloidosis. So the other reason it's particularly important to develop and try new drugs in amyloidosis is because the survival over the last 20-30 years has at least doubled according to studies. So patients are getting onto further lines of therapy and are requiring more treatments than they used to. Now, Ixazomib has been tested in a phase 1 trial which showed some initial promise with a response rate of about 50%. But unfortunately the phase 3 trial of Ixazomib was cut short as it didn't meet its primary endpoints. So with this study, we wondered if you combine the Ixazomib with lenalidomide, could that then increase its efficacy and make Ixazomib still an applicable drug to amyloidosis? And what we found is that whilst Ixazomib in the phase 1 study showed about a 50% response rate and lenalidomide has been reported anywhere between 50 and 60%, we had a greater response rate than that, up in the mid-60s, but not only that, we had more deeper responses. So at best response, over a quarter of patients got a complete response and just under half got either a complete response or very good partial response on the latest analysis. We also showed that translated to a benefit in progression-free survival. So on the latest analysis, the progression-free survival overall was 17 months, which went up to 29 months in patients who had a deep response, which was defined as either a complete or very good partial response. The overall survival was just over 29 months, and that went up to 35 months in the patients who had a deep response, so just under 3 years, which is quite promising. It is important to note that it's just 40 patients and it's a small study, but it potentially paves the way for a larger study with a larger cohort of patients receiving this line of therapy in amyloidosis. It's also important to note that these are patients who have had, on average, 2 prior lines of therapy, so they are pre-treated patients. So that does impact the efficacy of the drugs. And the final thing to say, which is important, is that the tolerability was comparable to both Ixazomib and lenalidomide alone. So we didn't have substantially more grade 3 or 4 side effects than the trials looking at both of those drugs alone, which suggests this is a tolerable as well as potentially efficacious group of drugs to use. I think the main most exciting area at the moment is the application of daratumumab, which looks particularly efficacious in amyloidosis. So the Andromeda trial is looking at incorporating daratumumab into first-line therapy. So I think the big question at the moment is, will that show a benefit, and will daratumumab come as a frontline therapy? Certainly in the UK, we're fairly limited in what's approved for amyloidosis at the moment. We use bortezomib first line, as is widely accepted elsewhere, and we can also use lenalidomide and melphalan, but many of the other drugs do need further trials with a view to getting approval, certainly in the UK, for use in amyloidosis, to expand the repertoire of drugs available to use. So it's certainly an area to watch.